Okay, hi everyone, my name's Molly. Thank you so much for coming to this BUSOG webinar today on Obs and Gynae in primary care. I'm very pleased to say that we are being sponsored today by the Teach Me series, so Teach Me Anatomy, Teach Me Obs and Gynae, who have kindly sponsored us, which means that we can now use Zoom for our webinars, so do check them out. We're joined today by Dr. Jess and Dr. Lizzy, who are going to host today's webinar. So thank you so much, guys.
Thank you very much for having us. We're honoured to be here and hopefully we can share some interesting experiences with you guys. I think Molly's just added some questions, some cases, so that you guys can mention what you want to hear about. You can obviously write some questions when we're speaking, and you can upvote which cases you'd like us to talk about. So I'll start off by just saying a little bit about myself. So Lizzy and I have worked together, so that's how we know each other. I'm a GP working in North London, doing kind of normal GP, but also some work with 111 and supervising students, which is how I met Molly. So I see gynae cases daily, obstetric and gynae cases. You may think that GP is all over the phone now, but it's not. Luckily, we're still seeing a lot of patients and examining people as well. I managed, during GP training, I did 6 months in hospital doing obs and gynae as well, which was a brilliant experience. And I've worked a bit abroad. I'm interested in global health, so I've recently worked, actually it's now a while ago, I worked a year ago in Greece in a refugee camp, lots of obs and gynae there, and especially as there weren't many female doctors. So we'll talk a bit about those experiences. Over to you, Lizzy.
Okay, thanks, Jess. So hello, everyone. My name's Lizzy. I am, well, I'm a GP locum at the moment in North London, same as Jess, which is how we know each other. But originally I trained in Ireland, did my university training there and did my foundation training there before coming to the UK. And then did my GP training in Cambridge, part of which I did 6 months in obs and gynae. And then after GP training moved to London and have been working as a GP here. So obviously similar to Jess, I've done lots of obs and gynae kind of in a GP setting, but then as of September, I'm also doing a post in a sexual health clinic and doing 4 days there. So I guess I'm seeing lots of women's health in the sexual health clinic as well. And I've also done the diploma of the Faculty of Sexual and Reproductive Health. So I do coils and implants as part of that. But yeah.
Perfect. So I hope everyone's able to see the screen. Lizzy, you can see it, right?
I can see it. Yeah.
Perfect. Okay. So we just wanted to start off by telling you a bit about what's different. And I presume many of you, I know we'll have a mixed audience tonight, many of you will have done some general practice and have an idea about this. But the thing that drew me to general practice is all of this, actually. The main thing about general practice is that it is holistic care. So it says holistic care, and then the one before the penultimate point there is limited time and lots of patients. So it's a bit of a contradiction, and we do struggle with time, of course. And at the moment, to be honest, things are extremely busy. But we never look at a patient's problem in isolation, unless it's one of the most straightforward things, which is kind of rare in general practice. Most of the time, things are not straightforward. So our second question is not going to be necessarily how long has this been going on for. Actually, probably the second question is going to be that, but the third or fourth question is going to be, tell me more about you, what's going on with you at the moment. And we try to look at the whole person, and that's really useful because so much of what we do in general practice is uncertain. So many times no real cause is found, and it's not necessarily a solely physical problem. And we're able to think about things on those terms, which in hospital, I know it's possible and it does happen at times, but I think it's often not the case. And the third point there, if you do some general practice, you'll hear this phrase used a lot, which is that we use time as a diagnostic tool. So at the moment, you may be aware patients are able to request an appointment within 48 hours for anything. And that sometimes means that they've had a symptom for a day and then they contact us. That is not normal general practice, but sometimes we need to just say, you know what, we don't need to investigate this. We can give this a bit more time. This is not necessarily a pathological symptom. And so we need to be able to judge when to investigate and when not to investigate. Whereas in hospital, things tend to be, once they get to you in hospital, they tend to be investigated. We tend to put them in a medical model, and we tend to, I guess, use our template. We do the biopsy, we do the scan, we know the algorithm. What do you say, Lizzie? Does that
Yeah,
really
probably back to kind of gynae, time, struggling with time and appointment time in general practice back when we used to do face-to-face. I think that is always a struggle, because it does take time, A, taking, proper history, and B, the gynae exam, especially, if it does take time. So that is definitely not in our favor. But yeah, I think time as a diagnostic tool is also really, really important, especially, I don't know about you, Jess, but a lot of the time women ring up very paranoid about periods and what one period's been like versus another one, which I always say, one period in itself is not so interesting, but it's what's happening over time. Yeah, so I would agree with all you've said.
There's definitely a pressure on us, isn't there, to say, yeah, this period I've been bleeding for 3 extra days, or I haven't had my period this month, we need to do something now, we need to have blood tests. And it's tempting just to say sometimes, okay, let's just do your blood test, but we're very aware in primary care of resource allocation. I'm going to mention in a minute some cases that I've had just this week, just as an idea, but for one of those examples is a lady, I think she's 39, wanting to conceive again. Last time she had IVF, and she hasn't actually started trying yet, but she's been using ovulation kits just to see if she's ovulating, and they say she's not ovulating, and so she wanted every test for fertility. And I'm kind of saying, well, I think you need to I know you're 39, but I do think you need to try a couple of months first before we dive into that. The last bit is definitely Lizzie's area here, but if you're interested in obs and gynae, or if you're interested in anything, and throughout your career in general practice, you can specialise to some extent. So people always talk about GPs with special interests, and that, before I did GP, I thought that was a really certain defined course. But actually, as a GP, if you have an area you're interested in, you can go for it. You can look into it as much or as little as you want to. So, for example, my trainer was very into HRT and menopause. So I ended up going to some conferences with her and becoming more confident with that. And then in my practice, people ended up referring patients to me for that. I did the obs and gynae diploma as well, which actually wasn't as useful as I hoped. But, if it interests you, you can end up doing more. And like Lizzie's done, you can then choose a career path which takes you more in that direction. And certainly some GPs work in hospitals, in gynae clinics. Some just take the lion's share of those sorts of patients in their own clinic. Lizzie, how did you end up going the direction you've gone in?
Yeah, during medical school, during training, people do always talk about GPs with a special interest, and God, I still remember that being a fascinating thing, and always thinking, oh, how do I get there? What do I do to become one of those? Kind of always having had a special interest in obs and gynae and sexual health. So I think initially you're a bit daunted, because it always seems like, this is something that other people can manage to do and not that you can do. But, I think what was said to me a long time ago, and not something I really believed, is that opportunities do come your way, and you just need to kind of take them as they open up. So when I was still doing my GP training, I did, as I said, the diploma of the Faculty of Sexual Health, and then started doing coils and implants in GP, which I really enjoyed. But then COVID put a bit of a stop to that, just because we didn't have kind of the time, the time allocated to basically do provide that. But then I worked a year as a locum GP, and then when that was coming to an end, I was just kind of looking for new jobs and what I was going to do kind of next, and just ended up basically seeing a position advertised in the sexual health clinic in Archway. So applied to do that, and I'm now working there 4 days a week, and then just doing 1 day of GP. So things do open up, and it's great. And for me, it's been really satisfying, getting back and doing procedures again, because since March I hadn't been doing any coils. And it is important that you just kind of maintain that skill set. And now I basically a clinic a week, and kind of with anything in medicine, the more you do, the more comfortable you get. So it's just, yeah, it's basically just finding that path.
Exactly. I think not that we want this to be an advert for GP necessarily, but there's definitely plenty of downsides as well. But flexibility wise, it is incredible. So I also have an interest in obs and gynae sexual health, but I've never had the opportunity to learn to do coils. And actually, as it turned out, being a locum GP has allowed me to then go and work in a refugee camp for a month. I ended up going away for 2.5 months, and I've been working remotely with a medical tech company, a charitable company, which is something I never imagined myself doing. But actually, once you have that qualification, you can dip in and out of it, and there is usually work available for GPs in one form or another. So I completely agree about just taking opportunities. And you kind of initially, just after I qualified, I think we're so used as medics to doing exams that I thought, oh God, I'm going to do the derm diploma now. I need to do another exam. I need to study more. But in actual fact, my whole family said to me, just stop, please stop doing exams and stop studying. And it was great because there are lots of other opportunities that then cropped up with the student project over COVID with 111 and other things. And I think that kind of eclectic career had always really appealed to me, of not necessarily knowing what I'm going to want when I'm 40 or 50, or and being able to have options open to me like that. And I can train to do the coil at some point, but I'm going to train to do that when I can then maintain it, because as you say, you can't just do that, learn the skill and then leave it with certain things in medicine.
That's the danger of it. And yeah, I know when I did my training, I think especially kind of if anyone is interested in kind of working abroad and doing kind of some aid work, especially kind of in the area of sexual health, there's lots and lots of opportunity. So yeah, definitely a good one to have.
Let's move on. I think the only thing we didn't talk about there was preventative medicine. Obviously, that's the other real joy of GP, is that you try and get in there early. You provide the contraception, you provide the smear tests, and sometimes hospital, to me, not so much obs and gynae, but sometimes hospital medicine feels a bit like picking up the pieces and extending people's lives, whereas before the quality could have been improved in a more preventative way. Okay, so just moving on, I think we've probably covered this a bit, but what do we actually see in general practice? Well, I think we see pretty much everything, and we have to be ready for everything and anything. Although we don't do much routine antenatal care, there's only a few hospitals and areas that still have GPs doing the routine antenatal care. We still look after a lot of pregnant women. Have a quick, you can see all of those. It's pretty much most areas. As Lizzie said, we don't have so much procedures. Most of it is I don't know what I'm trying to say there, but yeah, not so much procedural as in hospital. The cases that I just wanted to mention, so this is literally just over the last kind of week of clinics that I've done. I've had a 40-year-old with postcoital bleeding. She'd not had bleeding for 2 years because she'd been on the injection. So I brought her in and examined her, and we decided what to do next. I had an 89-year-old palliative care patient with dementia who had a cystocele, so a prolapse that previously she'd been able to reduce herself. Because of her dementia, she no longer can reduce. So we're trying to organise a pessary fitting, so a device to keep this prolapse, so the bladder has prolapsed outside of the vagina, to keep that inside. I had a couple of women with vaginal irritation, and also a couple of women with painful and non-painful vaginal lumps who needed examination. What about you, Lizzie? I expect you've got far too many patients to list.
I know it's going to be a little bit more because I do have the 4 days at the sexual health clinic, so I guess I see a little bit more. And then I find in my GP job now, because they all know what I do, I do also probably get disproportionate amount of kind of gynae problems and sexual health problems kind of triaged over to me, because they think I'll know what to do with them. But yeah, I guess kind of the commonest things I'm kind of seeing on a weekly basis is probably like vulval pain and vulval disorders, so lumps or rashes, vaginal discharge, lots of that, abnormal bleeding, and then lots of kind of contraceptive queries or problems.
Okay, so let's move on now to the cases. So we've got a few prepared, and of course we can answer questions or discuss any kind of case that would be interesting to you, but these are the ones that we've prepared. So over to you, Molly. Any news on the upvoting of case?
Yeah, so can you hear me?
Yep.
So the most popular one is contraception, by quite a way. Sorry, everyone, just to clarify, we have already posted the topic choices on the Slido, so please don't comment them again. We have deleted repeats just to make it a bit easier to navigate. I'm really sorry that I didn't make that clear initially. Also, if you have any questions throughout, please do post them in the Slido, and I can ask them throughout on your behalf. Thank you very much. And so, yes, contraception is the most popular one.
Okay, we'll come back to you afterwards so people have a chance to vote maybe. So contraception, over to you, Lizzy.
Yes, so this is my case. So I just thought it was a really interesting case, one that I did see at the sexual health clinic, but also one that you could definitely see working as a GP. Now, this young girl, 17-year-old, had been triaged on the phone and then brought in to see me. She'd been newly sexually active, had only had intercourse twice, but both had been unprotected. Her last menstrual period was 2 weeks ago, and I think the last time she'd had unprotected sexual intercourse had been 10 days ago. So I didn't know how today was going to work and whether or not we could get people involved, and mainly I was going to put it out as to if anyone had any ideas of what would be available to her. But I think that's not quite how today is working. So, I mean, I don't know how much people know about emergency contraception, but basically, in terms of kind of emergency contraception, there's obviously different choices. The most effective emergency contraception method is the post-coital IUD, so copper coil, which for this 17-year-old is actually the only option here, because the last episode of unprotected intercourse was 10 days ago. So basically, copper coils can be inserted anytime up to 5 days after kind of when somebody first ovulated. Now, in the end, this ended up not being not being the choice of the 17-year-old, because I think understandably for a 17-year-old getting a coil inserted, not that it's a contraindication, because we do have plenty of young people who do end up opting for either IUDs or IUSs. But I think for somebody who's never had a speculum examination, who's only had sex twice, I think she felt it was quite invasive. So we didn't actually end up giving her any emergency contraception. But it obviously did raise, a bit of kind of a red flag, because obviously she's become sexually active. And I think this is kind of where the preventative kind of in, because you need to think about, obviously, she's going to continue having sex going forward. So kind of a big discussion about kind of what, her ideas of contraception. Does she know about any kind of methods of contraception? And does she have any contraindications to any of the different methods? Because I think we'll go on to the next slide, but you'll see there's such a vast choice of different contraceptive methods out there, that you do want to kind of just discuss things like people's lifestyle, what they know of, and what's acceptable to them. And then also kind of another kind of good opportunity at this stage with somebody who's become newly sexually active is just kind of education and counselling about kind of, a healthy sex life, sexual, STI screening, when that's appropriate, what you would kind of recommend going forward, encourage the use of condoms as much as possible. So yeah, I just thought it was an interesting case in terms, because it tied lots of different things together, just brought up a lot of different questions.
I'm just going to ask Lizzy, quite often with women this age, I struggle because they often say, oh yeah, no, I will get contraception, I'll have a think about it, and I'll maybe just use condoms for now. And I think quite a few times I've then seen them come back either unplanned pregnancies. How do you go about, I feel like there's a kind of golden opportunity there to offer and then kind of proceed with giving something that's maybe long acting. How do you proceed, and how does that work?
So, I mean, I think that is quite common, because I think they can feel a little overwhelmed at this stage, that there's, all these different options. And I think, what to decide now. And ideally, somebody of this age, we do want to get them on some method of LARC, so more of a long-acting contraceptive, because, kind of compliance with taking a medication every day for somebody who's not really ever probably needed to take a tablet every day, it's not probably going to be the ideal method. Of course, that will vary from person to person, and obviously then LARCs, they're not just fitted right there and then in the clinic. So I would often really try and encourage something like a LARC, but then obviously maybe starting something when they're there, to say, how about we start this now, and then we organize an appointment. But then that's easy for me in the sexual health clinic, less easy in GP, because you have to say, well, can you contact the sexual health clinic and make an appointment to get this and this device, whatever you've decided with them, fitted, which I think, again, you're not sure whether that will happen or whether, they will come back. But I think trying to, maybe quick start something as a kind of tying over method, but really trying to encourage the LARCs, because just basically explaining to them, the need that they will have to be taking this medication all the time, which will, impact on their lifestyle. And, that if they don't, the risk of pregnancy, which is not really a situation we want them to end up in, if it can be avoided.
Molly, I'm just wondering whether there are any questions that are related, or
So I have a question, which is obviously with LARCs, I think I've found that people are really concerned about side effects. And I was wondering, what side effects do you find that people tend to be most worried about, and how do you kind of counsel them so that they are like fully informed about them, and hopefully persuade them to do kind of what you think is medically the best thing?
So I think there's a lot of horror stories with LARCs, and people will come and they will all know of somebody who's had a terrible experience with one form of LARC or other, which has completely put them off. So it's really important, I think, to explore with them, what that story is, because I think that will have made kind of an impact. And I think it's really unfortunate when somebody has a story about somebody else where either maybe their bleeding has gone haphazard, where they've put on weight, or basically they had a terrible coil fitting, to try and put that aside and say, unfortunately that was that person's experience, but your experience might be completely different. Because what you don't want them to do is, rule out a method, and then them not to be kind of, not to consider that as a valid option, because I think it is just very individual for each person, and people will get on, differently. So I think it's really important to counsel people about potential side effects, because obviously, there is potential side effects to each method of LARC. I think to kind of answer the question of what people are most worried about, I think I get a lot of women who are worried about weight gain. And I think this is a complete myth, because the only actual, the only method of contraception where there's actual evidence for weight gain is actually, the depot injection. But they will get so many women who say, oh, but my friend started this and they put on weight. So it's just really important to counsel them about whatever side effect they are actually worried about.
It never fails to surprise me, the variety of side effects people have. And I think I always highlight that as well, that everyone's so individual, and sometimes people do have really unpredictable side effects and dramatic side effects. But overall, that is not the case, and the benefit is so much greater. And I think the way people also quote some horror story they've heard, people like an anecdotal evidence. It's probably a terrible thing to say, but I often say to people, most doctors have the Mirena coil because it's brilliant. And it's true. I mean, I think most doctors I know have got the Mirena coil. And people quite like a kind of a kind of another anecdote to counter theirs, to be honest.
Yeah, they're always interested. They're like, well, what do you do, or what do you do?
And you're like, I don't want to talk about me.
Yeah, so but it is helpful. I think it's definitely helpful in this area being a woman, because you can talk a little bit about your own experience, because it's not something men have to deal with, really.
Perfect. Well, another question is, how common is a vasovagal response to coil insertion, and how do you manage that situation? Which I suppose is another kind of horror story that I've certainly heard loads from like my friends and peers.
Yeah, so I mean, I'm so I do a coil clinic a week, where I do about probably 6 coils in a row, and most weeks I don't have a vasovagal episode. So, I mean, I've definitely experienced them. And when they do happen, I think they are quite frightening for the patient. But I think kind of almost again managing in that preventative way. Because so what we generally do is we've taken the blood pressure kind of before the episode, and we take in the pulse. And then I'm very lucky again in the sexual health clinic that we're set up in a way that I do have an assistant, and then after the procedure they will take the blood pressure and the pulse again, and with anyone whose pulse is kind of below 60, we do just make sure and give that person a bit of time, and that their blood pressure is, if it's low, give them some extra time just lying down and recovering. But generally, even in the patients where they do actually get on a full-on vasovagal episode afterwards, generally, I mean, the recovery can be slow, and it does take up sometimes like half an hour of your time afterwards. But I think just explaining to them why it's come about, what exactly has happened, and that this isn't necessarily a contraindication to them having a coil kind of going forward, but that it just does happen. And I think really empathizing with the experience is important.
Perfect, thank you. And I think the most upvoted question, which actually came on before your case, was any tips on how to take a focus history in GP before offering a choice of contraception? What are your key questions, and what can be skipped in a 10-minute setting?
Yes, I don't know, Jess, do I have another slide? Oh no, I do. Sorry, it's right.
This one, yeah.
So this is kind of what I put up in terms of no, can you actually go back to the other one in terms of the choosing contraception? Sorry, yeah. So I mean, this is what I focus on in GP, kind of trying, because I think you just can't go through all the methods, because there is so many, and I find I end up getting sidetracked talking about one, then talking about the side effects, and so mainly kind of ask them really like important questions to kind of narrow down and what would not be suitable for them.
I was going to say, Lizzy, patients only remember so much, don't they? You have to, whenever you're trying to do something briefly, reassure yourself that if you give too much information, it's pointless. You've really got to try to narrow down early, haven't you, to make sure that the patient's going to retain.
Even I sometimes struggle with all the different methods. There's so many options. So if I feel like that, and I definitely have the experience, what is a patient going to feel like being overloaded with that information? So I think really important things are just checking out kind of what their lifestyle is like. Do they have a preference for something hormonal versus non-hormonal? Because that's very quick, because you can go talk about all the hormonal methods, and then the patient will say, well, actually, I don't want any hormones. So this is kind of what I quickly do. Check out, do they have a preference for that? Is there anything that they know about that they want to talk about? Because again, no point you launching into a big conversation about all the methods, and then they say, well, they've already decided or they've already looked into it. Then I think it's really important, obviously, checking early that there's no contraindications. So what is their medical history? Do they have any conditions which might make something like the combined pill not an option for them? And then also really important, just what their menstrual history is like and what problems they have, because this might make one method really more suitable than another. You know, if they have a history of heavy and painful periods, then, you know, something like, you know, either a Mirena coil or the Kyleena would be really, really suitable for them. But equally, you know, yeah, basically, because then you can kind of tie that in and just say, well, actually, this will make, you know, help with these problems really, really well. So that's mainly what I do, but I'm not saying that there's a right or wrong way about it.
I think in terms of exam settings and asking for students, definitely getting, exactly as Lizzy said, getting the patient's view is so crucial, because they're going to give you the tips as to how to narrow down.
I think maybe, shall we carry on and then take more questions as we go through? Or
yeah, we've got lots more cases. Obviously time's passed so quickly, so we could perhaps do another one, and then we can see how it goes with questions and just take it.
This is a case again I saw at the sexual health clinic. A 24-year-old woman with kind of 3 casual male partners in the last 3 months, had 2 episodes of unprotected sexual intercourse, had an IUS in situ, I think it was a Mirena coil, I can't remember exactly, and had presented with kind of a 2-week history of a very foul smelling green discharge. Also mentioned you know, that she had kind of ongoing lower abdominal pain, and did have a new history of kind of pain during intercourse, which I guess always is a bit of a red flag if there's a new history of pain during intercourse that wasn't there before. So I kind of, you know, obviously kind of top of your differential diagnosis and what you are thinking about in anyone who, you know, at the moment we would be speaking probably over the phone in the first instance, would be, is this PID? And the only way you can rule that out really is by seeing this patient and examining them, because that's just going to make such a big difference in terms of actually what you think is going on. So I think we have another slide there, Jess, do we? Yeah. So let me talk a little bit about pelvic inflammatory disease. So, you know, it is a clinical diagnosis, so very much based on the history, on the symptoms. But I think I can't stress enough that the examination, you know, in a case of pelvic inflammatory disease is really, really important, because there's so many patients referred to the sexual health clinic from GPs saying query PID, and you do a bimanual, and, you know, it really, you know, if there's no kind of pain on bimanual, you know, it's really quite unlikely that it is PID, or that's been my experience of it anyway. And I think you do also need to think about if we are actually treating somebody for PID, you know, they are going to be on quite a cocktail of medication, and it's not for a short time period at all either. So they're going to be on doxycycline, metronidazole, and they get a ceftriaxone injection. And the oral medication they will be on for 2 weeks. And generally with my metronidazole, a lot of people have a lot of side effects. So, you know, it is definitely a burden that you're going to be putting on the patient, that, you know, doing all this medication. So it's definitely not one I would treat over the phone. Definitely needs to be investigated and swabs taken and a bimanual done. The other thing, obviously, with PID that's really important is just partner notification, and notifying the relevant sexual partners that they do also get tested and treated. Kind of most cases, so 25% of cases of PID are going to be caused by chlamydia, plus or minus with gonorrhea, and then the remainder of cases are usually things like trichomonas, and then also mycoplasma genitalia, which cause basically pelvic inflammatory disease. I don't know if anyone has any questions.
I have a quick question about partner notification. So I know that in some areas they have the text messaging system where you can anonymously tell people. But if they don't, or the patient just isn't forthcoming with the information, do you try and persuade them to? And if you do, how do you go about persuading them?
So yes, I mean, we at the sexual health clinic, again, we can offer them, partner notification service. I think, back in the days where there was good kind of funding for sexual health clinics, they did actually have kind of health advisors who did a lot of work around that. Now that's not really being funded anymore. So as much as possible, we're kind of encouraging them to do it as much as possible. And I think kind of just exploring with them any concerns as to why they wouldn't, or any worries as to kind of the obstacles to it, generally helps with that. But definitely there is some patients who don't feel comfortable doing it, and then the sexual health clinic will take that on board if they can give the contact details of their partners. Then we will kind of anonymize it, and basically contact those people and let them know kind of that their partner has been diagnosed with an STI, and that they basically need treatment or tests kind of going forward.
We have another question here from Becky, who asks, if the patient says they won't tell their partner, do you have to contact them yourself for like any disease in particular? Or
so if the patient so it's not that if the patient says they won't, it's not that we would then overrule that, but you would encourage them as much as possible. I think just explaining to them, why, and also I think with STIs, the danger is many of them can be asymptomatic and then they are just spread. And I think bringing the patient around to that, obviously, we want to avoid kind of people being in the same situation as they are in, kind of just generally bring them in. I've not ever experienced it that then they refuse. Because most of the time it is just some kind of concern that they have, or kind of embarrassment or kind of shame, is kind of the main reason that they wouldn't want to contact their partners. Does that answer the question?
Yes, I think so. We have another question, which is, how do you manage a patient who is living with chronic pelvic pain?
Oh.
That's a big one, sorry.
That is a really difficult one. I mean, I think, Jess, you'll have had your fair share of these kind of patients in GP as well. I think probably chronic pelvic pain patients are going to be probably on that top list of most difficult patients, because I think there's so much psychosomatic involved, and it's a really sensitive, really difficult area, I think, to deal with. I think it really depends on the patient. It's really quite individual on how you manage them, but I think you try and make it as holistic as possible, and just, yeah. God, Jess, what would you say?
I mean, I think this is actually where GP comes in to its own. Having seen kind of chronic pelvic pain patients in gynae clinic and then seeing them in GP, I actually don't see, I don't see them as so different to people with other kind of locations for their chronic pain, where it's really frustrating for everyone because there's no answer often, and there's complete uncertainty about the future of that pain. And this is where I think it comes into more discussions about how you live despite the pain, and how it's much more about them as an individual, how it affects their life. I think the problem is that if we don't have the energy, and it takes, I think medicine in general takes a huge amount of energy, and if you don't have the energy and the enthusiasm that day, what we often end up doing with chronic pain of many kinds is to then start one after another of long, alternative pain medications, gabapentin, pregabalin, amitriptyline, you name it. And I can't honestly say I think with very few cases I've seen some improvement, but in the long term, I just don't really think they're very helpful. I think they're missing the point. Pain is an extremely difficult area that I think is poorly understood, as is psychosomatic, or whatever you want to call. Psychosomatic is a very taboo phrase when it's something so normal for patients and humans to feel pain for different reasons than just a physical cause. And often there is a physical cause, but I think there's other things we can offer. Pain clinic is one option, of course. There's usually long waits, but I think also talking therapies, I think just getting to know the person, talking about other stuff than their pain, knowing and hearing them, listening to that, and trying to de-escalate that panic about having long-term pain, which so many people have. But it's a really fascinating part of GP, especially when you're training and you get to be discussing these kind of problems that feel so difficult. We as doctors want to say, have this tablet, it's going to get better. Like, we found a cause. And we have to confront the fact that in so many cases with so many problems in general practice and in our patients across the board, we can't give them a solution right now, and we can't give them a certain answer. So I think we are the experts sometimes with that, although it's very, very, very tricky. Sorry, Lizzie.
No, I think it's that, like, with the condition and trying to kind of facilitate that rather than treating, because yeah, and especially I think this is a very useful scenario once they've seen a specialist and we have said, look, there is nothing we can do right now. And no one is saying with any chronic pain patient that it's all in your head. And there's a very interesting book called It's All in Your Head, which I recommend to anyone about. It's specifically about pseudoseizures or dissociative seizures, but a discussion of our failure to appreciate things that don't have a medical explanation in medicine, which is the majority of the work that we do and is not discussed enough in medical school and in training. And Molly, I always went on and on about it to you guys.
Thank you, guys.
Quick question about the management of the PID, if that's okay?
Yeah, sure, go ahead.
Sorry.
Hello? All right. Yes. So from what I understand, PID can be quite vague and it can be sometimes quite difficult to diagnose. So if, let's say, a lady with who you from the history, you might think that she might come from an STI causing this PID, and you treat her with antibiotics empirically, but then after the 14-day course, she comes back and the pain's a little bit better, but not quite better. What do you do at that point?
So, I mean, generally with PID, don't treat just based solely on the history. So she will have had swabs done, and I think then if the swabs all come back negative, and there is no kind of underlying cause for the PID, or for actually cause of PID found, I think then we are kind of going down kind of more of a pelvic pain kind of a pathway that we're kind of investigating for other causes, that we would look into it maybe with an ultrasound, but just investigate, what other causes of pain there actually is, if there hasn't been any swab found positive to be causing the PID. We do treat PID, so we treat them with the antibiotics, but then if the pain hasn't actually improved with them, then we know it's not PID, that's actually causing the pain. There's something else going on.
Okay. Hi, everyone. Could you just, thank you so much for your question, Gillian, but just please don't come on and ask, because if we want to post this later onto other platforms, then we'll have to take out your question because of permissions and whatnot, and it also can disrupt the flow of speaking. So thank you so much for your question, but please just put them in the Zoom chat on the Slido, where you can upvote them in the future. We've got another question here, which is, can you diagnose PID only based on deep vaginal intercourse pain?
No, so there's lots of other things that would kind of maybe alert you to PID. So it's not solely that they have pain during intercourse. So some patients just present with discharge. So usually other patients will present with kind of new onset pain during menstruation, so what we would call kind of a secondary dysmenorrhea. They might have postcoital bleeding, they might have intermenstrual bleeding. So yeah, there's lots of other symptoms that would be associated with PID. It's not just solely that they're having dyspareunia.
Perfect, thank you. And we have one more question. the person who asked that question says thank you, and we have one more question on the Slido on this case, which is, do you treat chlamydia, gonorrhea, etc. with the same antibiotic regime, e.g. doxycycline plus metronidazole and ceftriaxone?
So it depends very much. So if they come but they don't have PID, but you find that they have chlamydia, you're going to treat chlamydia, which is at the moment the guidelines are 7 days of doxycycline. Whereas if they have chlamydia and gonorrhea, then you're going to add in the so for gonorrhea you'll add in the ceftriaxone. But so PID is a 2-week course of doxy, metronidazole, and then an IM injection of ceftriaxone. But if you just have chlamydia, it's only 1 week of doxycycline. If you just have gonorrhea, it's just the IM injection of ceftriaxone. If you have chlamydia and gonorrhea but no PID, it's going to be the 1 week of doxy and the ceftriaxone. So it's a little bit different based on the actual presentation and what you're dealing with.
Perfect, thank you so much. And everyone, sorry, just to mention, we've been spammed once again on the Facebook event. So please do not click on the spam links. So yeah, many apologies for that. We're trying our best to control it, but we're just too popular with spammers. So when you're... So do we have time for another case, or shall we, we've got a couple of wrap-up questions here as well.
Probably a couple of wrap-up questions. I'm sure everyone's
okay.
doesn't want to be delayed on their Sunday night.
Yeah, so one here is so the person asking the question says, I really struggle with differentials of intermenstrual bleeding, postcoital bleeding, irregular menstruation, and postmenopausal bleeding. What would be the first line investigations or differentials for these presentations? I suppose there's probably a short way to answer that and a quick and a long way to answer that, but
I'll do the short one first, then I'll hand over to Lizzy. I mean, I would just say that I think we all do, and I think unless you're doing it every day, yeah, I mean, I think it's really good to check in every case, and there's a few things that you get used to thinking about. So I think it's always good to do an examination. It's always good to ask all of your general gynae history. You must always think about pregnancy, always think about STIs. So I kind of cover the bases, and then I always have a quick look at Patient UK or NICE guideline to make sure that I'm not missing anything. And I think with those things, you're covering the main things. You've asked about their smear, you've asked about their gynae history. Over to you, Lizzy.
Yeah, no, I agree with you, Jess. I think if you're struggling with diagnosis, it is very much, you will get your diagnosis. What do they say? 80% of the diagnosis comes from the history. So I think it all comes back to history taking, and just that you are asking, about, just because it might just be that the bleeding is actually linked to the contraception that they're on. So it's just important that you do have picked that up, that maybe that, they're either on something like the implant, which can cause irregular bleeding. And then also sexual history, just really important, because then obviously you're going to think about things like STIs, PID, whether that's actually, causing, and, smear history, are they up to date with that? Whether there's something like that going on. Just really important that you ask about, pain during intercourse, and what's new. Has it always been like, or has this changed? Is there a change from previously? Because that will also just give you a little bit of an idea. So I think it really does come back to history taking, and just taking a really detailed and good history, because then that's something you can come back to.
And in GP, but in the whole of medicine, always having it in your mind, not in such an awkward way, but ideas, concerns, expectations. We would always be asking as well, what's worried you? What have you Googled? Because it's just really good to have an idea of what their agenda is before you start explaining and reassuring them about something, when actually they might have a friend who's had cervical cancer or something very specific in their mind. So I always get that in quite early in the history as well.
Okay, perfect. And one last one, I think now, is this is from Marianne, who just wanted some clarification on the first case. Mm-hmm. If the patient's last unprotected sexual intercourse was 10 days ago, or over 5 days, how would the copper coil be appropriate, as there is a chance she could be pregnant, which apparently is a contraindication?
So I mean, so as I said, the copper coil is licensed as emergency contraception up to 5 days after kind of the expected ovulation date. So this, I think, 17-year-old, I think she had a 28-day cycle. So it's still, be licensed to use in her case. I mean, you would do a pregnancy test then, and you do need to counsel them. No form of emergency contraception is 100%. We do always get the patient to do a pregnancy test kind of 3 weeks after the last episode of unprotected sexual intercourse, because despite emergency contraception, they can still fall pregnant. And especially with something like the copper coil in situ, if a pregnancy is to occur with an IUD, and equally if there was in somebody with an IUS, the chance of that pregnancy being an ectopic pregnancy is obviously much higher. So yeah, no, it's really, really important to counsel them about those risks. Does that answer your question?
Yes, I think so. So thank you so much to Jess and to Lizzy for doing such a fantastic event. I found it really, really interesting and useful. Everyone's saying thank you in the comments. So thank you so much. We all really appreciate it. For everyone else, I'm just going to post a link to our feedback form in a second in the chat. And then I'll also put the QR code in about 30 seconds onto the screen. So if you could please fill out the feedback form, then you'll get your certificate, and it really helps us for all our future events. Please do apologise on our behalf for to any of your colleagues who couldn't get into the event. We're really sorry, but we are limited to 100 people just because of funding. So yeah, thanks so much again, guys, and I'll be online for a couple of minutes afterwards if anyone has any further questions, and we'll post the feedback form link. Thank you.
Thank you very much for having us.
Thank you. Lovely to meet everyone. Bye bye.